Awesome. Thanks, everyone. So yeah, as Dr. Dow said, my name's Gord. I'm the Thrombosis Medicine Fellow for this year. And Dr. Nicholson and I have been doing some research with regards to the use of DOAC-Stop and Hepzyme as it relates to lupus anticoagulant testing here at Providence Health. And so obviously the majority of this work is work that was already done by Dr. Nicholson, and he was kind enough to allow me to join for some of the data analysis of that. And so the primary goal of today's talk will be to present some of the data that has been collected and analyzed as it pertains to those neutralization agents that I referred to here at St. Paul's and Providence Health. But to preface some of this discussion and to incorporate it into a full Network Grounds talk, we're going to be talking about a few additional items today. I'll quickly review some of the pathophysiology of antiphospholipid syndrome. We'll review some of the commercially available diagnostic tests that we currently have for the lab diagnostics. We'll talk about some of the guidance statements that have been published with regards to the use of some of these tests for the diagnosis of antiphospholipid syndrome. And then we'll talk a little bit about how lupus anticoagulant testing works and how we can use DOAC-Stop or Hepzyme for patients on anticoagulation. Then we'll get into some of the data that we've collected and analyzed here at Providence Health. So I have no disclosures for this talk today. And as we all know, antiphospholipid syndrome is an acquired autoimmune disease characterized by arterial venous thrombosis and/or obstetrical complications in its various forms. We know that the pathophysiology seems to be rooted in autoantibodies that target phospholipid-dependent binding proteins, and it has historically been categorized into quote-unquote primary APS or antiphospholipid syndrome as an entity on its own, or quote-unquote secondary APS, or really an association with other autoimmune type illnesses such as lupus, Sjogren's, rheumatoid vasculitis, etc. And when it comes to the pathophysiology of the proposed mechanisms, I think we're becoming aware of several different antibodies involved in this process. Beta-2-glycoprotein 1 is one of the 5-domain plasma proteins that has a role in both coagulation and complement regulation in a normal, healthy individual. In its native closed conformation, it's relatively non-immunogenic. But when beta-2-glycoprotein is bound to an anionic phospholipid surface, it adopts an open conformation, and it exposes some of these epitopes that allow these autoantibodies to bind. When autoantibodies bind beta-2-glycoprotein 1, it can disrupt its normal anticoagulant functions, including inhibition of factor 11 activation, and it can alter the contact pathway regulation involved in the coagulation cascade. It also is thought to interact with a few other mechanisms, such as the EPO-ER2 receptor, which can influence protein C activation, thrombin generation, and the platelet coagulation cascade. And then we know that once these antiphospholipid antibodies bind to the open form of beta-2-glycoprotein 1, they can trigger further endothelial cells, platelets, monocytes, neutrophils, and really the complement system from there. This is why historically there has been a two-hit mechanism, usually something that has to involve some epithelial dysfunction, oxidative stress, something that may trigger the open immunogenic form of beta-2-glycoprotein to start, for example, and then cascade is set from there. I talk about this. This is just one, obviously beta-2-glycoprotein 1 is just one protein involved in this process with antibodies against it involved in antiphospholipid syndrome. But there are other antibodies that have also been implicated in this process. And really, when we talk about lupus anticoagulant testing to come, really what we're looking for is looking for these phospholipid-dependent antibodies that are causing all of this pathology. And so we are all familiar with the routine lab tests for the diagnosis of antiphospholipid syndrome. That includes the lupus anticoagulant test, which should involve two tests within it, really, is according to the guidance out there, we should have a DRVVT based test and then a PTT based test. And we'll talk about how those work and how they activate different parts of the coagulation cascade in a second. And then we are all familiar with the beta-2 glycoprotein 1 antibodies, the IgG and the IgM, as well as the cardiolipin, IgG and IgM. There are other antibodies that have been made available, not necessarily within BC that I'm aware of, but there is an IgA of the beta-2 glycoprotein that has been made available elsewhere. There's also the anti-domain 1 beta-2 glycoprotein 1, IgG, which, as I understand it, rather than testing for the antibody that attaches to the beta-2 glycoprotein 1, you're actually looking for the open immunogenic D1 exposed epitope of beta-2 glycoprotein 1 when there is a high prevalence of the immunogenic form present. And then there's also this anti-PS and prothrombin complex, IgG and IgM, that have also been discussed in the past. And I think most of us are familiar with the 2023 Euler classification criteria. And so this includes all of the clinical criteria, which is, as we know, macrovascular, both venous and arterial complications, the microvascular complications, cardiac complications with valve thickening or vegetations on the valves, the hematologic manifestations, the obstetrical manifestations, and then mostly what we're talking about today is the lab criteria. And so we all know that if there's one-time positive lupus anticoagulant, that would gain you 1 point on the classification criteria. Persistently positive would get you 5 points. And then the cardiolipin and the beta-2 glycoprotein are the two antibodies that are currently included in classification criteria. I do think it's important to just recall that these are classification criteria. They're not diagnostic criteria. And as a tool used primarily for classification for research purposes, we probably do gain some specificity at the cost of sensitivity. And so we may be underdiagnosing, so to speak, some patients if we were to strictly strict with a criteria such as this. And even within the Euler classification criteria publications, they say, first of all, the lupus anticoagulant testing should be performed based off of ISTH guidelines, which we'll talk about. And then they acknowledge that these thresholds set out for anticardiolipin and beta-2 glycoprotein, this moderate threshold of 40 to 79 and the high threshold of more than 80, should really be determined based off of standard ELISA results and not necessarily other testing modalities such as these new automated platforms. This does obviously raise a lot of questions because, like we'll talk about in a second, we're not necessarily using ELISAs on a regular basis when we do a lot of this testing. Even when we look at some of the other APS criteria out there, like the Sydney criteria in 2006, they also say, lupus anticoagulant testing should be done as per the ISTH guidelines, should be positive on 2 or more occasions, at least 12 weeks apart. The Euler criteria says the same thing. And then here they start to mention perhaps also including the greater than the 99th percentile cutoffs for anticardiolipin and beta-2 glycoprotein, also using standard ELISAs. So in late 2024, the ISTH had put out a guidance statement, which was an update on the lab detection and interpretation of antiphospholipid syndromes for the diagnosis of APS. I'll just highlight a few of the relevant parts of that guidance document for this presentation today. But with regards to lupus anticoagulant testing, they say that this lupus anticoagulant testing should involve two different tests. One of these tests should include the dilute Russell viper venom test, and there should be a second PTT-based test. For example, here at Providence Health, we use the silica clotting time-based test. And the ISTH would formally discourage testing on anticoagulation, but certainly acknowledges that there are clinical scenarios where it may be desirable to do testing on anticoagulation. And options for this would include strategies to remove DOAC. Furthermore, in this 2024 document, they recommend against grading the positivity of anticardiolipin and beta-2 glycoprotein into low, medium, or high positivity, acknowledging that this is a method-dependent categorization to do so, and that perhaps we should be setting the cutoff value for positivity at over the 99th percentile of normal controls to be considered positive result. And then interestingly, they do start to bring in some of these alternate tests into some of their recommendations for specific situations. This would be like the anti-domain 1 of the beta-2 glycoprotein test, and then the anti-PS prothrombin test, which can be considered in different situations. And so just not that I am a lab expert by any means, but I have been given the great fortune of having some education this year on how some of these lab tests work. I thought quickly I'll just review that. ELISAs, when we talk about beta-2 glycoprotein and anticardiolipin, these ELISAs that we are using to refer to these traditional thresholds, these are fairly time and labor intensive tests. These are historically done manually on the lab bench. And so they are more and more commonly being replaced by these solid phase-based assays, which offer an automated process. These would include technologies like CLIA, like the chemiluminescent immunoassays, these multiplex flow immunoassays, and other technologies such as flow cytometry. Within the lower mainland, the technology that we are using for measuring cardiolipin and beta-2 glycoprotein at, as I understand it, Providence Health will send out to Vancouver Coastal Health, and then right now this lab testing is done mostly at Vancouver General Hospital. This does not include the technology that Life Labs uses, but Vancouver General Hospital is using a technology called ALIA, which is very similar to an ELISA. It is done on an automated machine. It's done on a machine called the Fadia 250. And there is, it's called a fluoroenzyme immunoassay. It's very interesting. I went down a large rabbit hole yesterday looking through all of these cutoffs for these lab results because like you, I was probably in a similar mindset yesterday, wondering what am I going to start using as a cutoff and how does this really impact the way that I think about the Euler classification criteria when I try and apply it to a patient with a positive cardiolipin or beta-2 glycoprotein result. And the manufacturer has set out their definition of a negative, a positive, and a weakly positive result. And those cutoffs seem to be what we are using at Vancouver Coastal Health as well. And so, for example, a truly positive beta-2 glycoprotein IgG would be greater than 10. A truly positive cardiolipin IgG by the manufacturer standards would be greater than 40. And there have been several studies over the years looking at if the greater than the 99th percentile in healthy controls is going to be used as a suggested cutoff, what would that look like in terms of a result to use? And I'm not at all suggesting with these numbers that we start using these results. Really, in an ideal situation, we would have some local validation to do this, but other studies that have looked at samples of healthy controls and have identified the 99th percent upper reference limits have found values actually much lower than some of these numbers we have seen in the Euler classification criteria and the Sydney criteria, for example. much lower than the 40th percentile. And actually, even when you go back to the manufacturer's documents, I'm not sure that they post it here, but the sensitivity of these tests on any one test is actually quite low, acknowledging that a lot of the research done around the sensitivity and specificity of the test was using mostly the Sydney classification criteria. What I found quite interesting is that actually these 97.5% specificity-based thresholds, meaning if you had a positive result, be 97.5% specific for the illness, these cutoffs were actually lower than I expected to see, certainly lower than the 40 and 80 threshold. And so I don't propose this, like, I don't present this data with any proposal that we should be using a specific cutoff, but just for an awareness that, using the old Euler, or I should say, like maybe some of the older technology, the ELISA technology that the Euler classification criteria references may actually be misleading if we're using those cutoffs. Sorry for the bit of a sidetrack on beta-2 glycoprotein, anticardiolipin, and the other antibodies. We're going to return to lupus anticoagulant testing before we talk about our data locally. So the lupus anticoagulant testing should involve two tests, like I talked about. The DRVVT is truly dilute Russell viper venom, which will activate factor 10 to 10A and essentially trigger the common pathway in the coagulation cascade. And then we measure a clotting time in seconds. The PTT-based test will activate the intrinsic pathway, and then we measure that clotting time in seconds. The PTT-based test can use different technologies. Life Labs, as I understand it, uses different phospholipid sensitive PTT assays in their screen and confirm tests. Here at Providence Health, we use silica clotting time. So silica is the ingredient that will activate the intrinsic pathway and then allow us to measure the subsequent clotting time. So in theory, using two different triggers for different parts of the cascade should be able to pick up or detect different lupus anticoagulants and increase the sensitivity of the test overall. And so the first step when a sample comes to the lab is that there are baseline tests that are run, including thrombin time, INR, PTT, and the sample is spun to isolate platelet or plasma. The platelet poor plasma sample is what the DRVVT screen reagent gets added to. And like I talked about, this should trigger factor 10 activation, and the common pathway will be activated, and we can then subsequently measure a clotting time. The screening reagent that is used for the DRVVT test has a low phospholipid concentration. And then we report it as a ratio. So this would be the screening ratio, which is the patient's clotting time over a control plasma clotting time. If the screen is positive, then we move on to doing a confirmatory test. The confirmatory reagent for the DRVVT test has a much higher concentration of phospholipid. And the thought here is that if there is a lupus anticoagulant present, adding a higher concentration of phospholipid should shorten the clotting time. That's to say, we should be able to overwhelm the phospholipid-dependent antibodies and shorten up the clotting time in the confirmatory phase. The confirmation step also gets reported as a ratio, which is the patient's clotting time during the confirmatory test over, again, control plasma sample clotting time. And then the final result, which we all know as the normalized ratio, is truly a ratio of ratios where we take the screening ratio and divide it by the confirmatory ratio to get a result. And so really a positive result or an elevated normalized ratio would indicate that there was a shortening of the clotting time as we added phospholipid to this test, showing a phospholipid dependency to what is presumably a lupus anticoagulant or an antibody present. So that gets done just for the DRVVT test. And then this test gets repeated using a PTT-based technology. So instead of dilute Russell Viper venom, silica is used in both a screen and a confirm capacity, again with low phospholipid and then with high phospholipid during the confirms time, and then gets reported also as a silica clotting time normalized ratio here at Providence Health. And the in-house work done by Dr. Nicholson in the special hematology lab here, we have come up with cutoffs. So the DRVVT normalized ratio cutoff of 1.23, and then the silica clotting time normalized ratio cutoff of 1.29. And so that's some of the kind of methods behind the lupus anticoagulant test. And then as a caveat, obviously there are different reagents available and different technologies at different labs. And so a positive result at one lab and a negative result at the other does not necessarily confirm an overall negative result. You only need one of either the PDT-based test or the DRBBT test to be positive to confer an overall positive result for the test, and different labs may have different sensitivities. I'm sure many of us are aware that false positives can occur. With the lupus anticoagulant testing, I'm sure one that comes to mind is anticoagulants and heparin contamination. In theory, anything that confirms both the screen and the confirmed time equally should actually confer a negative overall normalized ratio. And so things like, common pathway factor deficiencies, the presence of anticoagulants, it is actually interesting that we would think of those as causing false positives when many of them in theory should lengthen clotting times, regardless of how much phospholipid we add to these tests in the screen and confirm. But we do see false positive and false negative results that we'll talk about from anticoagulants. And then we know that there's also other conditions that are associated with transient positivity of lupus anticoagulant. That's not necessarily to say that these are truly false negative results, but could these antibodies be circulating at certain times that are of no long-term significance, for example, such as during acute infection, inflammation, malignancies, surgeries, or is it just that the inflammatory state on its own is causing a false positive result? And so what are the options if a patient is on anticoagulation? We do have the option of adding DOAC-Stop and Hepzyme to these samples. There's still no great option for patients on warfarin. For patients who are on DOACs at Providence Health, you can order a DOAC-specific anti-10A level, so a rivaroxaban level or an apixaban level with a lupus anticoagulant at the same time, which, as I know, should trigger the DOAC-Stop to be used for that sample. And then for heparins, you can use a similar process. I believe you still order the heparin anti-10A level and the lupus anticoagulant at the same time, which should trigger for Hepzyme to be added to that sample if needed. And so what is DOAC-Stop? It's actually it's proprietary, so they're not going to tell us exactly what's in it, but they do say it's a charcoal-based absorptive neutralizing agent. Essentially, activated charcoal has been shown to absorb and neutralize DOACs. And so I suspect that DOAC-Stop is primarily a form of activated charcoal. And I hear that the cost of this is actually very minimal. So I actually wonder if there is anything beyond activated charcoal in it, but that's just speculation on my part. It has been validated for use in the coagulation labs to eliminate DOAC interference, especially for lupus anticoagulant testing, factor assays, and other clotting assays. Hepzyme is a bacterial heparinase-based neutralizing agent that we use in the clinical coagulation lab to eliminate heparin interference in any of these clot-based tests. It is manufactured by a company called Werfen. And so this is a product that is in the Hemocell line of products. And it is designed specifically for plasma testing environments where we can't remove, or the patient is on unfractionated heparin or low molecular weight heparins, and the presence of the anticoagulation may distort results. Then we can add Hepzyme. And so I'm going to hand it over to Dr. Nicholson just to talk about some of the lab-based validation that has been done, and then I will talk about some of the prospective clinical data that we have analyzed.
Thanks, Gordon. Okay, so as Gordon's kind of laid the groundwork, there's this clinical and laboratory challenge to confidently and accurately perform lupus anticoagulant testing, clot-based testing, in the setting of patient specimens when those patients are on anticoagulant medication, because this clot-based testing will be susceptible to interference by anticoagulants. And all the guidelines recommend avoiding LA testing during anticoagulant therapy. ISTH, the British Society of Hematology, and also the Clinical and Laboratory Standards Institute. However, we know that it's frequently clinically impractical to discontinue anticoagulant therapy prior to testing. Patients may have had thrombosis, they're treated with anticoagulant, and then a thrombophilia workup ensues. And so to try to deal with this clinical and laboratory conundrum, we sought over the last year or so to validate the use of these two neutralizing agents for the purpose of LA testing. Next slide, please. So this particular study, which was part of a larger lupus anticoagulant testing validation work that we did in the lab, myself and Stephen, had three objectives, really. So we want to validate the use of these two neutralizing agents in LA negative and positive control specimens, and also then eventually in patient samples as well for clinical testing. And so we sought to, one, use them to neutralize DOAC and unfractionated related LA assay interference. And then two, to preserve true LA detection. And then finally, we wanted to make sure that the use of these neutralizing agents would work and perform well in patient specimens when they're sent in for LA testing, when those patients were receiving different anticoagulants, DOACs and unfractionated heparin. Next slide, thank you. So the testing was done here in the lab. We use an automated coag analyzer called an ACL-Top 750, and all of our reagents that we use in this lab are made by the same company, Werfen, and they're called Hemocell IL Instrumentation Laboratories. This is the same reagent instrumentation combination that is used at VGH for routine coag there, and then also at Fraser Health, but it is different, for example, from the platform used at Children's and Women's Hospital. And there are two phases to this particular project. First, an analytical validation, and then after that, a prospective evaluation of clinical specimens. And this data, we've been collecting it for a while, essentially over the last almost 2 years. So the first phase of testing, this is the analytical validation. So it was a small spiking experiment, basically. So we took 4 LA negative plasmas and 2 LA positive plasmas. And in each of those specimens, we performed testing at 4 different stages. So first, NEAT, or baseline testing in these LA negative and positive plasmas. We collected a bunch of data on baseline coag testing. And then what we did was we performed the same testing post-neutralization, but before anticoagulant spiking. So this was to ensure that the neutralizing agents themselves didn't create an appreciable change in the baseline test results before we'd even added anticoagulant to the plasma specimens. Then we did in vitro anticoagulant spiking, and we repeated the testing. And then finally, after that, we performed neutralization with the respective neutralizer for the anticoagulants that we spiked with. And then the second phase was the prospective clinical evaluation, which we've been collecting specimens slowly over the last year and a half. And so we've got clinical specimens from patients receiving apixaban. That's the largest sample size, 70 patients. Rivaroxaban, we had a few more patients than 6, but we had incomplete data, so we've been left with just 6 patients. And then 19 patients who were receiving unfractionated heparin. So for both those phases, the testing included the following different assays here. So baseline coag testing with INR, PTT, and thrombin. Then we performed lupus anticoagulant testing with our 2 different test systems that we'd validated, DRVBT and silica clotting time. And we performed screening test, confirmatory testing, then calculate the normalized ratio using the 2 cutoffs that we validated over the last 2 years there. And then we used the relevant anti-10A assay to measure drug levels before and then after removal of anticoagulants to demonstrate effective removal of those anticoagulants. Oh, just go back once more, please. Sorry. Then the in vitro spiking study. So we spiked with the 2 DOACs, apixaban and rivaroxaban, at 3 different concentrations shown here. And then for unfractionated heparin, we spiked at 2 different concentrations shown here. Okay, now we'll just go through the results. So for the analytical validation first. So that baseline testing after we added the neutralizing agents, we saw that those agents themselves didn't appreciably alter the clotting times, and importantly, didn't change the interpretation of LA positive or negative in drug-free plasmas. And we'll look at apixaban, the spiking studies. So what we observed was that apixaban causes a disproportionate prolongation of the DRVVT confirmatory clotting times. So this is the opposite pattern for what you'd expect for a lupus anticoagulant. So in both cases, the clotting times are prolonged. We've spiked with an anticoagulant, but the confirmatory clotting time is prolonged more than the screen clotting time. And then what happens is when you go on to calculate the normalized ratio, the consequence is this downward shift of normalized ratios, and we observed that at all the 3 different concentrations of apixaban. So in the LA negative plasmas, the average or mean normalized ratio decreased from basically 1.99 to 0.70. And those numbers specifically are for the highest concentration of apixaban we spiked with. And then in the LA positive plasmas, again, the average normalized ratio decreased from 1.7 to 1.54. But we actually saw the same magnitude of change at the 2 lower drug concentrations for apixaban as well. So this was not a drug dose-dependent effect that we observed. Comparatively, effects in the silica clotting time were minimal. We didn't observe the same downward shift of the normalized ratios. And overall, we saw no false positive or negative DRVVT or silica clotting time results. And DOAC-Stop effectively removed the apixaban and restored all the results to baseline. For rivaroxaban, so this had the opposite effect in terms of interference compared to apixaban. So what we saw here was a disproportionate prolongation of the DRVVT screen more than we saw prolongation of the DRVVT confirm. So this is the same pattern that you'd expect for a lupus anticoagulant. Screen clotting time is prolonged more than confirmatory clotting time where you're using higher phospholipid concentration in the reagent. So what this produced when you go on to calculate the normalized ratio, what we saw was a dose-dependent upward shift of the normalized ratios for the DRVVT test system. So in the LA negative plasma samples, the mean normalized ratio increased from 0.99, essentially 1, to 1.38. And importantly, you notice there that crosses the threshold for our cutoff for the DRVPT normalized ratio, which is there highlighted in red, 1.23. So what that means is for the interpretation is false positive normalized ratios we're seen in 1 out of 4, 3 out of 4, and all 4 LA negative controls at the low, intermediate, and high drug concentrations that we spiked with for rivaroxaban. And then in the LA positive control plasmas, again, the mean normalized ratio increased. It went from 1.7 to 2.68. And we saw similar magnitude of changes at all 3 drug concentrations for the LA positive plasmas. Again, effects on silica clotting time were minimal, and we saw no false positives in that test system. DOAC-Stop gain effectively removed rivaroxaban when we measured levels pre and post neutralization, and it corrected all this interference and false positive results that we observed. And then finally, for unfractionated heparin, so we spiked at 2 concentrations. We saw minimal changes at 0.2 international units per mil, but at the higher concentration of 2, we saw, again, like rivaroxaban, this upward shift of normalized ratios. And in the LA negative plasma samples, the mean DRVVT normalized ratio increased from 0.99 to 1.46, again crossing the threshold for abnormal results and positive results. And we recorded all 4 of the normal plasmas had false positive DRVVT results at that concentration, the higher concentration of heparin. And we saw 1 false positive this time in the silica clotting time, where 1 normalized ratio was above the cutoff. Hepcine again effectively removed all the unfractionated heparin and corrected this interference. I just want to point out here, so we didn't see any changes or false positive results at the low concentration, which was 0.2 IU per mil. It wasn't until we tested with the higher concentration that we spiked with that we saw false positive results. And actually, both the DRVVT and silica clotting time reagents include a heparin neutralizer, polybrine, in the reagent mixture. And when you look at the product inserts, the commercial vendor guarantees they validated that results in the silica clotting time, for example, will be unaffected by unfractionated heparin up to 0.5 IU per mil, which is a lower concentration than the highest concentration we spiked with. And then again, for the DRVVT, they guarantee results are unaffected by unfractionated heparin up to 1.0 IU per mil. So it's not surprising that we didn't see any changes at this lower concentration here. It wasn't until we increased the concentration above the levels that polybrine is able to successfully neutralize that we started seeing interference and observe these false positive results. Okay, so here's a figure summarizing everything that I just described. So I'll just talk you through this. What we've got here basically is anticoagulant interference signatures in the DRVVT normalized ratios. So on the vertical axis is DRVVT normalized ratio results. And then you'll see this gray horizontal dashed line here. That's showing or indicating our locally validated normalized ratio cutoff for the DRVVT of 1.23, where results above that cutoff are considered abnormal and we would interpret as being indicative of the presence of a lupus anticoagulant. Then the horizontal axis here shows 3 clusters of colored bars, and each cluster is associated with one of the 3 different anticoagulants that we spiked with. The mean or average baseline DRVT normalized ratios in the LA negative control plasmas are shown in blue. That's the blue bar. And those are compared with values after spiking, which are shown in red, with apixaban, the first cluster, rivaroxaban, and then unfractionated heparin. What's shown here is only the highest concentrations that we spiked with. And then the green bar shows percentage change from baseline. And so what we see illustrated here is that in the first cluster, apixaban, this causes a downward shift in the normalized ratios by disproportionately prolonging the confirmed clotting times more than the screen. And this is consistent with theoretically a potential to mask a lupus anticoagulant, although we didn't actually observe this in the analytical validation. So the percentage change from baseline observed here was negative 29%. Then in contrast, the other clusters here are showing that rivaroxaban and unfractionated heparin both produce an upward shift in the DRVT normalized ratio by disproportionately prolonging the screen clotting times more than the confirm, the same pattern that you see in lupus anticoagulant, and hence they're showing a lupus anticoagulant mimicking pattern. And then the percentage from baseline are shown for both plus 39 and plus 47% respectively.
Awesome. I will move on to talking about some of the prospective clinical data that had been collected over the lab. And so we had a total of 70 apixaban samples that were included for analysis. Um, we did demonstrate effective removal of the DOAC. The average apixaban level was 160 nanograms per mil prior to DOAC-Stop, and the average level following was all the way down to 3. The DOAC-Stop was able to correct one false positive normalized ratio result. And like Dr. Nicholson had just presented, we did see this tendency for apixaban to have this lupus anticoagulant masking effect, whereby there were 8 false negative results that were then corrected with DOAC-Stop. And just to say, this was not an entirely um, obviously healthy population. We had 40% after the use of DOAC-Stop that were still positive in their lupus anticoagulant result overall. So we saw a similar magnitude of this downward shift observed in both the analytic and the clinical component of this data. And then, like mentioned earlier, we had to exclude a few rivaroxaban samples. There had been a few, for example, that were, I think, flagged with the wrong type of anticoagulant in them, or for a couple of other incomplete data or reasons. Again, we were able to demonstrate effective removal of the rivaroxaban with an average level 144 brought down to 0.2 with the use of DOAC-Stop. And then we were able to correct what was reported as a 50% false positive samples that then returned to negative results after the use of DOAC-Stop, which again confirms this ability of rivaroxaban to create this lupus anticoagulant mimicry. After neutralization, half of these samples remained lupus anticoagulant positive. And this was similar to the pattern seen in the analytic validation that had just been presented. There were 19 samples for patients on unfractionated heparin, and we were again able to demonstrate appropriate removal of the anticoagulant. The average heparin level was 0.68 prior to, and then 0.08 following Hepzyme. And Hepzyme was able to correct 4 false positive normalized ratios, again demonstrating that unfractionated heparin can have a tendency to induce lupus anticoagulant mimicry, as had also been seen in the analytic phase. After neutralization, only one of these 19 samples remained positive in their DRVVT result. And then again, similar to what we had seen with the analytic validation, the silica clotting time did not actually show any misclassification in the normalized ratios in anticoagulated patients. And so this, again, is a figure just demonstrating everything that I discussed. So here on the vertical axis, this is now the proportion of positive DRVVT normalized ratios. And then on the horizontal axis, we have the different anticoagulants, both prior to and following neutralization agents. So we saw actually an increase in positive normalized ratio results with the apixaban samples after DOAC-Stop was used, indicating that potentially we are seeing again these false negative results in patients on apixaban when a DRVVT normalized ratio is checked prior to the use of DOAC-Stop. And then again, we confirm that the rivaroxaban in a patient population has a tendency to induce lupus anticoagulant mimicry, which we were able to correct with the use of DOAC-Stop, similar in the unfractionated heparin group. And so in conclusion, we were able to demonstrate from both the analytic and clinical data that there was effective removal of anticoagulants using the neutralization agents. We saw that apixaban can mask lupus anticoagulants in certain cases, and we saw that rivaroxaban and unfractionated heparin can mimic lupus anticoagulants in certain cases. These findings are consistent with what has also been described in the literature elsewhere. There are several other papers that also discuss similar patterns seen when looked at rivaroxaban, apixaban, heparins, and even into like dabigatran seems to actually have a similar pattern to rivaroxaban in other literature as well. And so we were able to reverse these interference patterns without affecting the drug-free or true lupus anticoagulant positive plasma results. And we were able to restore assay specificity and enable accurate lupus anticoagulant interpretation using DOAC-Stop and Hepzyme when these anticoagulants can't be safely interrupted. And so we do feel that these results support incorporating neutralization agents into routine lupus anticoagulant testing algorithms in cases where it's not safe to take patients off of anticoagulation.